I'm going to cover everything on pediatric cardiology. So it's pretty buzzwordy on exams, but this should pretty much cover everything you need for the matrix and from the past papers that we've got. And here we've just got a little picture of a baby's heart. This is ectopia cordis. Some babies, I think 8 in a million, can have the heart born outside of their body. It's not going to be examinable, but it's pretty cool. So really, you can break down Peds cardio into pretty much 4 different diseases. First, we've got congenital heart disease. Then we've got rheumatic fever, Kawasaki's disease, and infective endocarditis. And then you can break down your congenital heart disease into acyanotic heart disease, so your not blue babies, and then your cyanotic heart disease, which are your bluish babies. Your acyanotic heart disease can then be split into 2 categories. So you've got your left to right shunts, which are really when you've got some kind of hole in your septums in your heart, or traveling through a patent conduit that is connecting 2 tubes that shouldn't be connected. Or you've got your obstructive. So these are your like stenoses, similar to your adults, your aortic stenosis and your pulmonary stenosis. And then we've got our cyanotic heart disease, which you can remember by the fact that they all begin with the letter T, and you can also figure them out by counting to 5. So we'll go through that in a bit more detail as we go through the slides. But before we start, I thought it would be important just to quickly go over a bit of pediatric cardiophysiology, because they are different to adults. And a few ways that they are is that, 1, fetuses have a placenta. And the placenta is a very low resistance circulation. And what that means is that it's very easy for the left heart to pump into it. And the second thing is that the fetuses are filled with fluid in their lungs. And this creates a very high pulmonary vascular resistance. And so the right heart has to pump against very high pressures to pump the blood through the, that circulation. And so if we combine the 2 together, we've got a higher right-sided pressure versus the left side. And so we're going to get right to left shunting across any kind of shunts or holes connecting the 2 systems. So if we look at our different shunts here, we've got the foramen ovale, so that's connecting the right atrium to the left atrium. We've got the Ductus arteriosus, which is shunting blood from the pulmonary artery to the aorta, and the Ductus venosus, which just shunts blood from the, basically to the IVC to bypass the liver from the umbilical vein. So yeah, this is very different to the adult heart, where the left side is the higher pressure system. Then let's see what happens when the baby gets born and we clamp the placenta. So if we clamp the placenta, then we're going to lose that really low systemic vascular resistance, kind of almost like a fistula kind of organ. And so we're going to get an increase in systemic vascular resistance for the left heart. Secondly, the amniotic filled lungs would notice this lack of oxygen from the placenta. So it's going to stimulate the brain to trigger the newborn to take a breath. That's going to open up the lungs, and then we're going to get a low pulmonary vascular resistance. And if we combine these 2 together, then we now have higher left-sided pressures than right-sided pressures. And so our shunts are going to reverse because it's the opposite. So our foramen ovale is now going to close because it's kind of like a flap. The ductus arteriosus is going to reverse its directions. And it's also going to close because the placenta produces prostaglandins, and those prostaglandins are lost when it's clamped. And then thirdly, the ductus venosus also degenerates. I think that's also prostaglandin related. And that should be about all you need to know about Peds cardiophys. If you break it down, it can be quite simple. Looking at acyanotic heart disease, the main things to look at with the left to right shunts are your holes in your septum. So we've got atrial septal defect, ventricular septal defect, so between the ventricles, AV septal defect, so between both the atrium and the ventricles, and your patent arterial ductus arteriosus. And generally the fizz that happens is similar to all of them. So we get blood that's entering the right heart from the left heart because of that pressure differential. And what this means is that the right heart is going to be getting all of this blood flow to pump into, and that's going to cause all the strain on the right side of the heart. It's going to cause pulmonary hypertension. And when you do your typical heart investigations, like your ECG, your chest X-ray, and your echocardiogram, you'll notice kind of right heart strain findings. So, you know, like your axis deviations, your hypertrophy, your increased pulmonary vasculature. And for most of these, the echo is the gold standard because you can actually just see the hole in the heart and the flow. So this means that the symptoms are going to be pretty similar. So it's going to be hard to differentiate on your systems review or in your written exams, but usually they get a failure to thrive, breathing difficulties. They might get a high heart rate. They're not really eating as well. They're a bit more tired and irritable, and they're more prone to lung infections. And as they get older, they're kind of less good at exercise tolerance. And these are typical heart failure symptoms, so you can treat them with typical heart failure medications that you give for adults, such as your ACE inhibitors, diuretics, and digoxin. All right, so let's go through the first one. This is atrial septal defect. It's in the name. It's a hole in the interatrial septum, as we can see here. And usually it's going to be either a defect in the ostium primum or the ostium secundum. Most commonly it's the ostium secundum, around 70%, and that's usually isolated, whereas the ostium primum might be associated with more other abnormalities than the heart defects. And you also want to look out for risk factors. So the main buzzwords are Down syndrome and fetal alcohol syndrome. It's not as common as ventricular septal defect. Only 8% of congenital heart disease makes up ASD. And it's generally asymptomatic because you're still getting your oxygenated heart, your oxygenated blood pumping from your left side of your heart. It's only when the patient is stressed, so they're getting, exerting themselves, that they might get a bit of shortness of breath, and they might be a little bit more prone to infections because of that stress on the right side in the lungs. So the main thing to look for on exams is that they have this characteristic soft ejection systolic murmur. And then they also have a fixed wide S2 split, and it's most commonly heard at the upper left sternal edge. So if we break this down, we've got increased volume within the right ventricle because of the blood moving from the left atrium into the right atrium and then eventually into the right ventricle. So this increased flow will then go across this pulmonic valve, and that's going to cause your ejection systolic murmur. The second thing is that since you've got more blood flow through the pulmonic valve at the end of your systole, it's going to close later. And so that's why you've got your S2. And now the reason it's split is that normally inspiration would decrease intrathoracic pressure, and so increase venous return to your right atrium, and then decrease your blood flow to your left atrium as the blood wants to stay in the lungs because the lungs are expanding with inspiration. So that makes the pulmonary valve open for even longer, while the aortic valve would be open for shorter. And that's what we call an exaggerated split. But in atrial septal defect, the pressures are equalized because there's a hole between your left and your right sides of your heart. You can also get a diastolic murmur, which is basically when a bit of blood flows across the tricuspid valve. And otherwise, you don't really do too much for it if it's small. They self-resolve on their own. You can close them if they are troublesome and are causing symptoms. And this is done around the ages of 2 to 5. And that can be done through a catheter or open heart surgery. And the other kind of thing to go over is that there's a thing called a patent foramen ovale. It's different to an atrial septal defect in that it's basically just when the two septums, your septum primum and septum secundum, don't close properly. And it doesn't really cause many symptoms. The only kind of situation where it would is if the patient is coughing or does the Valsalva maneuver. And what that does is that causes an increase in your right heart pressures over your left heart pressures. And this would then open up that flap. And so if someone was in a situation where they're hypercoagulable, they're forming clots in their veins, which can happen more often than people think, then they can shoot through from the right side of the heart into the left circulation and then cause a stroke or a bowel ischemia. But again, this is less common in kids. The most common thing is ventricular septal defect. So this is basically similar to atrial septal defect, but it's just the hole between the ventricles. And it's around 30%. And you get this loud pansystolic murmur at the left lower sternal border, and you may get thrills. The main reason you hear this in small ventricular septal defects is because there's more turbulence. Whereas when you get this big, large hole, then there's not really much turbulence. So you're not going to actually get much of a murmur. It's pansystolic because basically the blood's throwing during systole when the ventricles are contracting. And the symptoms are depending on the size. So if it's small, then it's asymptomatic because it's not causing much of a problem. But when it's big, that's when you get those classic heart failure symptoms, failure to thrive, chest infections that we've talked about. And you also won't get a murmur if it's large. So you get biventricular hypertrophy because both your left and your right side are pumping blood to both your lungs and to your limbs and your gut and everything else. And you can treat this in a few different ways. So you can encourage a high calorie diet to overcome that failure to thrive. If they've got heart failure, you can treat the heart failure, and you can close the hole if it's causing a lot of symptoms and if it's a really large defect. The other kind of thing to look out for in exams is that they might only present, say, at 2 to 4 weeks. And the reason for that is because the lungs are still expanding until the newborn is about 2 to 4 weeks old. And so when the lungs are still expanding even more and more and more, then there's going to be a greater pressure differential between your left and your right side of your circulation. And so the shunt's going to be exaggerated as the baby reaches 2 to 4 weeks old. Hence your heart failure symptoms would come on. Atrial septal defect is very, very, very buzzwordy in the exams. Just remember basically one thing. If you see Down syndrome on your MCQs, it's probably going to be AVSD, and it's pretty much going to be cured with surgery. So patent ductus arteriosus is also pretty high yield. It's basically when you've got the ductus arteriosus that should close when you clamp your placenta and your prostaglandins are stopped and your shunt's reversing, but it doesn't seem to close. And usually this happens in a premature infant. So if it doesn't close by day 1 to 2 of life, then they can either be symptomatic or asymptomatic, and the symptoms they would have are your typical heart failure symptoms. But what you want to look for on exam is that it's got this continuous machine-like murmur, and that's going to be going to the left infraclavicular area, and it's going to radiate to the back. The other thing you get is bounding peripheral pulses. And the reason for this is that it's, well, one, it's in the area of it, and two, the aortic pressures are always going to be higher than your pulmonary artery pressures. So you're always going to get this flow through it, and that's what's causing that kind of continuous machine-like murmur. Other buzzwords on the exams are, worsening ventilatory requirements, and the fact that this would really only present around day 1 to 2 of life, because that's when the patent ductus arteriosus should become no longer patent, but in this case it still is. So we treat it with indomethacin, and the reason you treat it with indomethacin is because it's a prostaglandin inhibitor, and so it's going to get rid of your prostaglandins in another way, and so hopefully you should get it closed. Otherwise, you can use a catheter to ligate it, which is when they've got symptoms if it's bad, or you can do it at around 1 to 2 years of age, and this is to prevent infective endocarditis because congenital heart disease puts you at a high risk of that. Cool. So that's pretty much all of your acyanotic heart disease, which involve your left to right shunts. The obstructive ones are your stenoses, and then your coarctation of the aorta. And so you're not getting enough blood to your limbs peripherally. And so you're going to get pallor, cool extremities, poor pulses, shock, low urine output, etc. And so you're not going to get cyanosis though, because you're still getting oxygenated blood when it does get there, unless it's very, very, very severe. And yeah, you diagnose it with your typical cardio investigation, so ECG and echocardiogram. So aortic stenosis, it's similar to an adult in the sense that they're asymptomatic until it gets really bad, and then you get, your SAD mnemonic symptoms. Again, like adults, ejection systolic murmur, right upper sternal border, and you might get a click, and then slow rising pulses. So these are all very similar to adult AS. You can balloon it, you can repair the aortic valve. Similarly with pulmonary stenosis, except for the one caveat is that pulmonary stenosis is a lot more common in kids. And the reason for that is that when you're doing your exam, you need to look for these congenital syndromes that are more likely to produce pulmonary stenosis. So look at rubella, look for Noonan syndrome, look for Alagall, and then Tetralogy we'll talk about in a bit soon as well. Again, they're really only bad when they start to become quite severe. And this will also be an ejection systolic murmur, this time in the left upper sternal border. Something to note is that the pulmonary stenosis is a wide split S2, but it's not fixed like your ASD as well. And again, yeah, similar investigations, echocardiogram, you can dilate it with a balloon and you can repair it with surgery. So coarctation of the aorta is probably the most high yield out of your obstructive acyanotic congenital heart disease. So this is basically a narrowing of the aorta, and it can either be preductal or postductal, but in kids it's generally preductal. And to go on a bit of a sidewalk on this, if you note that after birth, we use the pulse oximetry on the baby's right hand, That's the preductal oxygenation. And the reason that's important is because that best reflects the oxygen to the brain. After that, we can use the feet because it's just less finicky. Just a little random fun fact. When you're looking at coarctation of the aorta, look for Turner syndrome. As far as symptoms go, they can be asymptomatic, or they can have lower limb cyanosis or underdeveloped legs versus arms. And the reason for that is if you look at where the coarctation is, that's where the restricted blood flow is going to. So, you're getting all right blood flow through your subclavians, through your brachiocephalic, to your upper limbs, but the legs aren't really getting much. And then if it gets really bad, you can get heart failure. So in a similar vein, if you do the blood pressure as an investigation, look for a differential in that blood pressure because you're not getting enough blood to your lower limbs, so the pressure is going to be a lot lower. And also radiofemoral delay because blood is taking longer to get to your legs. Similarly with the poorly palpable pulses, the ejection systolic murmur is also trying to get the blood to flow through that coarctation, causing that turbulence. And then you might also get compensatory hypertrophy of your left and right ventricles. Other things to note, so you can get rib notching, and that's due to collateral circulation. Usually that's because you've got decreased blood flow to your lower limbs. So you're going to try and compensate by getting increased flow through your subclavians, down your internal thoracic artery, and then into your intercostal arteries that then will connect to your descending aorta. So that can happen in quite severe coarctation, and it could be a buzzword. The other thing to think of is prostaglandins. And the reason we can use that to treat it is because if you keep your PDA open, then you can, because this is preductal, the patent ductus arteriosus can give a channel for the oxygenated blood to go to your lower limbs. But to actually cure the coarctation, you've got to do surgery for it. And that should be about all you need to know about coarctation. So moving on to cyanotic heart disease, the baby is blue. And so you can look for that in your MCQs. It's a lot rarer. It's only 1 in 4 of your congenital heart disease. And you mainly get a right to left shunt. So now we're not getting oxygenated blood to our peripheries. So the baby's going to look blue. They generally occur after the shunts close because if the shunts are open, then you can still get some of the oxygenated blood to your system. And you can use your differentials by using the 5 T's or 1, 2, 3, 4, 5 rule. So Truncus arteriosus, which we'll talk about more in a bit, is really just one trunk. So that's 1. Transposition of the great arteries. So aorta, pulmonary artery are switched. That's 2 vessels. Tricuspid valve atresia, basically you get a non-developed tricuspid valve. So 3. Tetralogy of Fallot, it's got 4 pathologies and tetra means 4. And then total anomalous pulmonary venous drainage is 5 words. So, it's like a 5. There's a few other ones which are pretty low yield, Epstein's, hypoplastic, and Eisenmenger's, but we'll talk about that in a little bit. And yeah, similar symptoms, heart failure symptoms that we've talked about, but also the fact that cyanotic heart disease is a little bit more severe. So neonates tend to pass away within the first year of life if they're not treated. The other thing to do here is to note that you can get cyanosis with both cardiac disease and respiratory disease. And so with our respiratory disease, we can differentiate that from our cardiac disease through what we call the hyperoxia test. And that's where we give the neonate about 10 minutes of 100% oxygen and we see if they improve with their oxygen saturation. If they don't improve, then it's going to be cyanotic heart disease because we're still going to get this right to left shunt. We're still going to get deoxygenated blood instead of oxygenated blood into our peripheries. Whereas in lung disease, we're kind of compensating by giving them a lot of oxygen. So yeah, similar cardiac investigations for this. So number 1 is Truncus arteriosus. So basically, if you think about your embryology, which you don't really need to for the MCQ, basically the aorta and the pulmonary artery trunk are connected. And so you've got both left and right heart blood going into both of your symptoms. Your buzzword for this is the Jaws syndrome. Otherwise, catch-22 is a good mnemonic for that. And you'll notice you have a harsh systolic murmur over your lower left sternal border. And that's because you've just got all this blood going through your ventricular outflow tracts. And that's also why you've got a loudest too. So yeah, bounding pulses, diagnose it with an echo, and you've got to repair it surgically, or the neonate's gonna pass. But mainly remember the Jaws syndrome for that one. Transposition of the great vessels. So similarly, instead of there being no septum in between your aorta and your pulmonary artery. This time, the septums have failed to spiral properly, so there's been a switch. So our right side of the heart is now connected to our aorta going into our limbs, and our left side of the heart is now going to our pulmonary artery, which is going to our lungs, which is then going to come back to our left atrium. So we've got two parallel circuits, and they're not going to be connected unless we have our shunts there. It's actually relatively common out of your cyanotic congenital heart disease, around 20%, and it is associated with other heart abnormalities. Risk factor buzzwords for your exams: diabetes in the mum, fetal alcohol syndrome, old maternal age, and rubella. And they're dependent on the shunt, because if you don't have an ASD, a VSD, or a PDA really, then you're not going to have any connection between your two parallel circuits. So the baby's not going to get oxygenated blood to anywhere except for its lungs, which are oxygenating itself anyway. So they're going to have severe cyanosis around day 1 to day 2. And the reason we look at this day is because that's when your PDA closes. And you can get and you generally get an absent murmur as well, because there's no actual stenosis that's occurring here. Other things to note is you do a chest x-ray, or they give you a chest x-ray on exam, and you look for this egg on string appearance. And that's kind of due to this right heart enlargement over the right atrial border. And it just looks like an egg. And then, you've got your string here. So that's another buzzword. You do the echo to diagnose it. And since it's ductal dependent, we give them prostaglandins to try and keep it open. And then you've got to do a urgent arterial switch surgical correction. And that should be as soon as possible, ideally within the first 2 weeks of life. Cool. So tricuspid valve atresia is basically when we don't have a tricuspid valve. The other thing that we know is that you have what we call right ventricular hypoplasia. So here we don't really have a right ventricle. And instead, this tiny little ventricle that's on the right side is actually connected to our left ventricle via ventricular septal defect. It's the third most common. So, tricuspid 3, third most common. And usually what happens is we get this left ventricle that's pumping all of our blood to both our peripheries from the aorta and also to our pulmonary artery. Now, the reason we need an ASD as well is because otherwise, when the blood comes back through your SVC and your IVC, it's not going to be able to go anywhere, because you don't have this tricuspid valve or this connection between your atria and your ventricles. So again, it's going to be dependent on your shunts or your septal defects, and you can treat it with a prostaglandin infusion, or what we call the Norwood-Glenn-Fontaine procedure, which is a 3-step surgery, very complicated, don't really need to know it for exams. Cool. So Tetralogy, probably most common and highest yield of your cyanotic congenital heart disease. Basically, it's got a tetrad. So we've got pulmonary stenosis. We've got right ventricular hypertrophy to compensate for that pulmonary stenosis. We've got a ventricular septal defect. And we've also got this overriding aorta. So this aorta is kind of over both of our kind of left and right ventricles. Buzzwords again, DiGeorge syndrome causes this. Down syndrome also causes this. And on exam, you look for what they call TET spells or cyanotic spells. And this is basically where the baby cries, or they're sick, or they've got some kind of stress, and then they become cyanotic. And the reason for this is that when the baby's crying, you get this increase in your pulmonary vascular resistance. And so you're going to get really high right pressures compared to your left side pressures. And so you're going to get this right to left shunt. So you're going to increase the amount of deoxygenated blood to your left side of your system and then to your peripheries. So hence you're going to get an exacerbation of your cyanosis and of your symptoms. The way we treat this is by, if they're little, you can bring their legs up, or if they're an adult, well, if they're an adolescent, we can get them to squat. And what this does is it kinks some of your peripheral veins, I think particularly in like your lower legs, and this increases your systemic vascular resistance. And this then increases the left-sided pressures, reverses the shunt, and then relieves the symptoms. So some kids might end up doing this naturally because they find that they can breathe better because of it. As for buzzwords, the murmur is a single loud S2 because of that pulmonary stenosis, and you get a harsh ejection systolic murmur at the left sternal border. So again, from the pulmonary stenosis. We don't really get a murmur from the ventricular septal defect because it's quite large, like we've talked about. So cyanotic babies, they have a spell, they cry, and they're first going to get cyanosis around their extremities, so the fingers and the toes, and around their mouth. So investigations, generic heart investigations, ECG, chest X-ray, echo. Buzzword is your boot-shaped heart due to that right ventricular hypertrophy. And your echo is diagnostic, but they can also pick it up during your antenatal investigations. So you've got to repair it surgically. Otherwise, you can treat your heart failure with what we've talked about. And if they've got a TET spell, then you can give them oxygen, knees to chest, and you can give them beta blockers or fluids as well. Again, so total anomalous pulmonary venous drainage is very low yield, but it kind of is there for complete mistake. It's very rare. And what happens is your pulmonary veins, instead of going back to your left atrium, they go through this aberrant vertical vein that then connects to eventually your superior vena cava and back into your right side of your heart. So you're not really getting your oxygenated blood into your left side of your heart unless you've got some kind of septal defect. So in this case, most of them will have an ASD. The infants are very, very sick. And the main thing you look for is the snowman appearance on your chest X-ray. And that's kind of due to this apparent vertical vein that's causing this kind of increased opacities in your superior mediastinum. And yeah, you need surgery. It's a complicated surgery to repair this. Cool. Other very buzzwordy conditions. So we've got hypoplastic left heart syndrome. Just think of this as you have a very small left ventricle. So kind of the opposite of your tricuspid atresia. And then the triad is a small mitral valve, the tiny left ventricle, and then you also get a small ascending aorta. So in this case, you're quite ductal dependent, as we can see here, and your right ventricle is doing most of the work for that. The other one is Ebstein's anomaly, and that's basically where you've got this deformed and displaced tricuspid valve, and it's associated with maternal lithium use. So that would be the buzzword if you were doing an MCQ. Finally, we've got Eisenmenger syndrome, and basically this is actually something that happens with your acyanotic heart disease. But when your acyanotic heart disease gets really severe, you get this left to right shunt because you're causing all of this pulmonary hypertension, increasing the pressure on your right side, and eventually that'll actually get higher than your left-sided pressures. So your shunt is then, what's originally a left to right shunt will now become a right to left shunt, and then the baby is going to become cyanotic. Cool. The other thing is that babies have thin chest walls, and turbulence is therefore very easy to hear. So they're actually very common for babies to have murmurs. So to remember what's innocent murmurs, which is benign, and what's pathological, just think of your 7 S's. So they're soft, so low amplitude. You've got systolic, short duration, single, symptomless, small, and sensitive. So, you can get them to bend their head, for example, or sit up, and that would either make the murmur exaggerate or make it go away. The other kind of buzzwords to look for in exams are musical or vibratory descriptors of the murmur itself. And the different ones you'll find are stills, which is the most common. It's related to flow and it occurs in your 2 to 6 year olds. It's a vibratory low frequency murmur, and you hear it on your left sternal border and your apex of your heart. And it's louder when it's supine or if they're kind of sick, like dehydration or fever. And you got to differentiate that from your VSDs. The other one is your pulmonary flow murmur. And this is basically what happens is when you're really young, so this occurs in newborns 1 to 2 months of age, they have a really proportionately larger pulmonary artery compared to their less developed, more distal pulmonary arteries. So you've got more turbulence. And as the baby grows up, eventually that murmur goes away because those more distal arteries get bigger. You look for a high-pitched murmur. They might have pectus excavatum, and your differential is pulmonary stenosis. Otherwise, systemic flow murmurs, sometimes you can get this high-pitched, harsh murmur over kind of your supraclavicular area, and that's just from blood flowing to your aorta and your head and neck vessels. And then you've also got your venous hums, which are basically made from blood returning back to the heart from your great veins. These are kind of low-pitched, continuous, and they're also softer when you turn your head. And those are more in kind of your 3 to 8 year olds. And that's pretty much it for your congenital heart disease. The others are a lot smaller as far as relevance goes, but you still need to know them. So we've got rheumatic fever. What you're going to get is you're going to get a child. There might be Aboriginal or Torres Strait Islander origin or from a dependent developing country. they're going to get an ERDI. This ERDI is going to be a streptococcal pharyngitis. And then 10 days to 6 weeks later, they're going to have joint pains, they're going to have fevers, they might have heart problems. And this is due to molecular mimicry. Your immune system's going to think that, you know, these certain areas of your body are actually strep pyogenes and attack it. And you're going to present with Jones criteria. So this is basically the mnemonic to remember. They're going to have joint arthritis, they're going to have carditis, so either heart failure symptoms, or they're going to get the valve disease. They're going to get subcutaneous nodules. They're going to get erythema marginatum, which again is a rash we'll talk about in a bit. And then Sydenham's chorea, which is basically they're going to present with these sporadic jerky movements in their extremities. And they also have minor criteria. So if they get a bit of joint pain, that might suggest rheumatic fever. You do an ECG, they have a prolonged PI interval. Not sure why, but that's also a suggestive factor. They might be febrile and they might have elevated inflammatory markers. And so you need to have 2 major criteria to diagnose this, or 1 major criteria and 2 minor, plus evidence of a group A strep infection. So that's why we do investigations, and that's what we'll talk about next as well. And the reason we care is because if this becomes bad, you can have rheumatic heart disease or carditis, which can lead to heart failure, or you can have Sydenham's chorea, which is basically abnormal neurological disability, which can become really debilitating for patients. So just to go over Jones, so the joint arthritis has a few characteristics. It tends to affect the larger joints. It tends to be less than 5. And it's migratory. So the joints might be your shoulders, and then it might move to your hips or your knees, and it moves around in that kind of pattern. The O is kind of representing a heart, and this is because it's causing carditis, and this can occur a few months after the streptococcal infection. In rheumatic heart disease, you're going to get inflammation of your heart, but also of your heart valves. And one of the things that happens is you get heart valve failure, and the most common valve is your mitral valve, and that's going to be mitral regurg. Here we've got your subcutaneous nodules, and these are just painless, firm nodules. They're quite rare, usually on your extensor surfaces, and they're more just to fill out the criteria. Here we've got your erythema marginatum, and so they're kind of these serpentine maculopapular rash, and then you also look for your central clearing. Bosman exams might be smoke rings. And your Sydenham's chorea, so jerky hands, jerky feet. They might also get jerky muscles in their face and tongue. And this can occur up to years after the initial infection. So as we mentioned before, during criteria, we also need to get evidence of the streptococcal infection. So we can do that through either culturing the throat, doing your anti-streptolysin O titers, or your anti-DNase B titers. The other investigation we need to do is your heart investigations, particularly your echocardiogram, so that we can monitor for the valve function and also for heart failure. You can also do your inflammatory markers, so your FBE, ESR, CRP, and your ECG as well for that prolonged PI interval. So these are from the rheumatic heart disease guidelines. The way to treat it is you admit them. If they've got arthritic pain, you can give them paracetamol or NSAIDs or tramadol. If they've got the streptococcal infection, then we need to give them antibiotics. The antibiotics of choice is your intramuscular benzathine penicillin G. That's given as 1 dose. Sometimes you can give a second dose afterwards as well. Or if they don't want an injection, then 10 days of oral phenoxymethylpenicillin. If they have carditis, give them heart failure medications. If they have chorea, then carbamazepine or valproate can help. And for both carditis and chorea, since it's an inflammatory response, you can give PRED as well. The other thing to think about is prophylaxis. So if they have rheumatic fever, they might be at risk of getting it again. They might be at risk of getting rheumatic heart disease. So the first line treatment is benzathine penicillin intramuscular, and that's going to be every 3 to 4 weeks. But a lot of people don't like injections. So the second choice would be phenoxymethylpenicillin or penicillin V, and that's twice daily. And if you're allergic to your penicillins, then you can give erythromycin. And the duration of this prophylaxis is actually really long. So you give it for 5 years or until they're 21, whichever is longer, if they don't have the carditis, rheumatic heart disease. If they have mild, then it's 10 years or 21. If it's moderate, then it's 10 years or until they're 35. And if it's really severe, then it's for 10 years or until they're 40, whichever is longer. Otherwise, repeat echocardiograms to monitor heart function. You might need to replace the valve. And if they have dental procedures, then any of your heart disease can increase your risk of infective endo. And so we need to give them prophylaxis for that, which we'll talk about when we get to that slide. Otherwise, you can, if you're doing an OSCE, you can say involve ATSI worker input because they're the at-risk demographic. All right, so Kawasaki's disease, just to go over quickly, it's a medium vessel vasculitis. Medium vessel includes your coronary arteries. And the thing to remember for this is crash burn. So this is the mnemonic for your diagnostic criteria. So if we start off with the burn, you need to have around a 5-day history of fever. And this fever is generally quite high. So we're talking like 39 degrees Celsius. Your crash is going to stand for conjunctivitis. So as we can see here, rash. So this is going to be a kind of non-specific, what we call polymorphic rash. It can be in any shapes and sizes. Adenopathy, mainly cervical. You can get a S would be for strawberry tongue. So we can see here we've got this very erythematous, inflamed edematous tongue, as well as the cracked lips. And then your H is going to be your hands and your feet, and they can peel, they can be red, and they can be edematous as well. The main thing we need to do is diagnose it based on having at least 4 or 5 of these, and they need to have around 5 days of fever. But what we do in practice is we can diagnose it before they reach 5 days if we're pretty sure that they're going to have it. What you need to do is we need to investigate for coronary aneurysms because they're the major complication of this. And so we do an echo diagnosis for baseline, and then at 6 weeks after the treatment course to make sure that the heart is doing okay. You can also do other investigations too for increased inflammation. They might have a bit of sterile pyuria as well, and blood cultures for other differentials. And the main thing we do to treat is we give them IVIG. This is going to be most effective within the first 10 days of illness, but some people still do it if they think it's ongoing inflammation. Otherwise, this is one of the rare situations in kids where you can give aspirin, and you do that to try and reduce your risk of your coronary aneurysms and then consequent thrombosis, myocardial infarction, etc. And the reason that we don't normally give aspirin is because there's a syndrome called Ray syndrome, which is kind of this liver-involved encephalopathy that can happen in kids who take aspirin. But in this case, the risk versus reward is more in favor of taking the aspirin. And some places would also give corticosteroids if the kid is at really high risk of getting Kawasaki's disease and the complications of Kawasaki. So if they're young, if they're in shock, liver involvement, heart, the heart is showing signs of involvement, or if they're Asian demographic as well. And finally, we've got infective endocarditis. So basically, this is when you have an infection of the heart valve, similar to adults, and it's actually really rare in children unless you've got a pre-existing heart disease. So we're talking, cyanotic congenital heart disease, rheumatic heart disease. If they've had heart surgery and they've got indwelling foreign body or prosthetic devices, that could be a nice place for bacteria to grow. That's a high risk too. Or if the baby's premature or overall just not as well as, other babies. Other things to look out for is dental procedures. So that can increase your risk of getting bacteria that can then track down into your heart, as well as certain operations such as gastrointestinal or genitourinary procedures. Usually it's staph or strep. Your HASIC group is another kind of group that can cause infective endo, and rarely it can be your fungi. So Staph aureus would generally cause your acute infective endo, similar to adults, where Strep viridans causes your more subacute infective endocarditis, which might present a bit slower, more insidious. And the other thing to note is that, just a buzzwordy thing, Strep viridans is your most common culprit in children with underlying congenital heart disease. You look for signs of the infection, so fever, myalgias, arthralgias, headaches. And then you also look at your heart involvement. So they might get failure to thrive, they might get heart failure. And similar to your adults, if you've got a fever and a murmur, then you really need to have your high suspicion for infective endo. Rarer in kids, but you can still get them, is your Osler's nodes, your Janeway lesions, which are your kind of nodules on your hands and your fingers, your Roth spots in your eyes, and you can also look at splinter hemorrhages in your nails as well. And of course, you're going to get a murmur if you've got valve involvement. So you diagnose it through finding the bacteria in the blood, so blood cultures, very similar to adults, as well as an echocardiogram. And usually a toe is going to be the most accurate way of picking this up. Some places do a transthoracic first, and then they do a toe. That's another option too. You worry about valvular damage, so damage to the valve causing regurg and heart failure, or you can get an abscess of this bacteria forming. or septic emboli. So, you know, the bacteria increase your coagulation, you form a clot, and that can go somewhere and cause complications there, or vasculitis. And so you treat it similar to the way you treat adults. So IV benzylpenicillin, gentamicin, and flucloxacillin. The main reason we give gent is that it gives you kind of synergistic efficacy with your fluclox. And this is a 4 to 6 week antibiotic regimen. If you've got heart damage, you can also give surgery, and you can treat the heart failure if they got heart failure with the medications we've talked about before. If they have dental procedures and they've had infective endo, or they're at really high risk, like when we're talking about rheumatic heart disease, then we give them amoxicillin for prophylaxis. And if they have a prosthetic valve, then we give them vancomycin plus gentamicin plus flucloxacillin for more broader coverage. And yeah, so for MCQs, I'd really recommend just going after the faculty past paper questions. They're very, very buzzwordy. They're quite simple. You should be able to answer them with everything you've got in these slides. Otherwise, MCQ banks, got a few guidelines in here. Hit me up if you have any questions, and thank you all so much.